Is this thing still on?
Sounds like they heard us. We are seeing some change.
We need to continue to disrupt the status quo.
And now the work begins.
You are now about to witness the strength of nursing knowledge.
Welcome to the Gritty Nurse Podcast, an unfiltered discussion on health and healthcare. My name is Sarah Fung.
My name is Amie Archibald-Varley, and we are your hosts. Our Toronto Star and the Globe and Mail national best-selling book is available now. Get your copy of The Wisdom of Nurses today. You can get a book for purchase at any of your local retailers like Indigo or Chapters, or pick up your book online through Amazon or other types of retailers. It's also available in various different formats like audiobook and on Kindle. If you read it and you loved it, please leave us a review.
Please make sure you subscribe on our YouTube channel where you can watch our podcast in video format. Like, share, and leave a review. If you're listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, leave us a rating and review. Thank you to all our listeners and sponsors who continue to support us.
Your support makes our podcast possible, and we're grateful for the partnership and for you believing in our work here at the Gritty Nurse Podcast. Stay gritty. Hi, and welcome to the Gritty Nurse Podcast, an unfiltered podcast related to health and healthcare. We have a great episode today. We are going to be talking about the CMA's apology towards Indigenous people and towards Indigenous health. So, does the apology take it far enough? Are all the steps that they've outlined and required, will it actually take Indigenous health to a different place? Has the apology been accepted? I think these are all questions that we need to ask. Again, also, when we put things down on paper, how far do we see the action? Today, we have a great guest who's going to be able to describe all of these different aspects and share her insights in relation to this recent CMA apology, as well as what health equity looks like for Indigenous people. Sarah, take it away for our guest today.
Yeah, our guest today is actually both Indigenous and a member of the CMA, which stands for the Canadian Medical Association. So we're really lucky today to have Dr. Jamaica Cass. She is a member of the Mohawks of the Bay of Quinte Turtle Clan. Dr. Cass practices Indigenous health as a primary care physician on reserve at the Tyendinaga Mohawk Territory. In addition, as an assistant professor of the Department of Family Medicine at Queen's University, she currently supervises both undergraduate clerks and family medicine residents. Dr. Cass completed her family medicine residency at the University of Calgary, where she served on the Indigenous Health Working Group in the Department of Family Medicine. Prior to her residency, Dr. Cass spent 4 years in New Orleans, Louisiana, where she completed her medical doctorate at Tulane University. With an extensive background in science, Dr. Cass earned her PhD from Queen's University in breast cancer molecular biology before pursuing a career in medicine. She was recognized for several institutional, national, and international awards, including the American Association for Cancer Research, MICR Scholar in Training Award, the Terry Fox Foundation Transdisciplinary Award, and the Robert Sutherland Fellowship. While a student at Queen's, she was active in Indigenous mentorship and advocacy, serving on the Indigenous Council of Queen's University and the Native Students Association, and mentoring Indigenous undergraduate students. Welcome, Dr. Cass, to the Gritty Nurse Podcast. We wanted to start by asking you how you got into medicine, if you could kind of share that story, and really just how that led to where you are now.
Yeah, what a wonderful question. And thanks so much for having me. It's a big question. And I think like many folks who end up doing a lot of the different sort of cross-sectional work that I do, there are so many aspects of my journey that impact where I landed. And so I'll maybe try to summarize some of those for you. So I am a member of the Mohawks of the Bay of Quinte, and when I'm not wearing my sort of academia hat, I work as a primary care physician in my home First Nation of Gondege, which you may know as Tyendinaga, which is about halfway between Toronto and Ottawa, just south of the 401, so in Southern Ontario. And I grew up not far from there. I was raised by a single Indigenous mother. I was the youngest of four. And growing up, we didn't, have a lot of money. There were times when we faced like food insecurity, housing insecurity, and we're unstably housed, like lack of like basic resources, which I think is like a really common story with a lot of Indigenous families. And certainly, although I don't think I really understood what a health disparity was, I could see that, my family on my Indigenous side certainly didn't experience the same level of health and wellness as other people, but I didn't really have the language yet to describe what that was. It was really unfair. And I think like a lot of, young people, when I had sort of decided that maybe university was a possibility for me, my mother didn't graduate high school and neither had anybody in her family before her. I, was really interested in science. And so I applied to some science programs and I was accepted to most of them. I think I was accepted to all of them. Anyway, so I decided to study biology. I knew I liked biology, but I wasn't really sure what within that I might do. And like many 90s kiddos, certainly I wanted to be a vet. And so I went to Guelph because it's where the veterinary program is in Ontario. And while there, I took courses on like genuinely everything. I took apiculture, which is beekeeping. I took courses on different horticulture. I took mammalian physiology. I took like an aquatic toxicology course, which is fish diseases. But I got
Wow.
interested in cancer.
Interesting.
And so doing cancer research in the summers at U of T, I thought, okay, this is, something that I could, I could do this. And so I applied to grad school because to be a cancer researcher, you need an advanced degree. And I was accepted. And so I moved from Toronto to Kingston and I went to Queen's and started a master's in breast cancer molecular biology. And as I was kind of working through my master's, I was interested in the research, but research funding is incredibly competitive, and you have to just absolutely love it to be able to commit and dedicate the time, energy, and effort it takes to get some of that funding. And having been a person who was always involved in sort of customer service, very like people-facing things, I missed that. I was working in a lab with the same four people with no windows, and I just really missed connecting with people. And it was really hard for me to kind of swallow that work I would do now actually would be applicable to human health for 10 or 15 years. And I really
Right.
needed, I think, to see something more immediate. And so, I got kind of talking to my family and talking to some of my friends and sort of thought, maybe I should be a doctor, which is kind of a weird place to be because, my mother didn't graduate high school and nobody in her family did. And I didn't know any doctors that looked like me or had the same like lived experience that I did. And so I was just, kind of going along and I was like, well, I'll apply to med school and, we'll just kind of see what happens. And so I applied in Canada and the US and I didn't, that was the time when you had to take the MCAT, didn't know a lot about the MCAT. And so, I got a job teaching an MCAT prep course so I could get some
Oh,
free textbooks so I could take the MCAT. And I did that. And I stayed in my lab and I did a PhD. And at the time, medical schools typically start in January, or sorry, excuse me, September, like all other school does. And because my graduate supervisors had to take medical leave, I ended up finishing a semester later than I had intended. But I was accepted to a program in the US where if you had a biomedically related PhD, you could condense the first couple of years of med school. So I handed in the corrections to my PhD thesis on Christmas Eve, and I moved to New Orleans, Louisiana to attend Tulane Medical School January 6th. And I kind of never looked back. I can remember I had a mentor who at the time was the director of the Indigenous Student Center at Queen's that I was talking to. And I kind of said, I think I might apply to medical school. And she said, you should become a family doctor. We haven't had a Mohawk doctor on territory in something like 60 years. You should
wow.
do
Wow.
that. And I should do that. I should absolutely do that. And so I went south and I was way late a little bit. I actually got really interested in surgery. And so when I finished medical school, I actually thought I was going to be a surgeon, had breast cancer research experience, and I thought I'm going to go and be a breast surgeon. So I came back north. I moved from the most humid place in the continental US to one of the driest, coldest places in Canada. And I spent 3 years in surgical training.
Wow.
And it was, yeah, yeah. And it was kind of over that time, I can remember being in an emergency department at one of the inner city hospitals, and there was a gang war happening. And when you get stabbed in the chest, the way that you treat that, ironically, is somebody else stabbing you in the chest and putting a chest tube in to reinflate the lung. And because the people there use, knives and kind of stabby implements, I had put so many chest tubes in that night that I ran out of chest tube kits.
Oh my
And I'm
God.
kind of just having this like epiphany, like, is this what I want to do when I'm 50?
Right.
And and I kind of decided no. And
Fair.
and that was sort of the beginning of my I guess reconnecting to the reason that I got into medicine, which in fact wasn't that, but it was maybe the possibility of like serving my community and giving back. And so I transferred to family medicine, and I had two babies and and became a family doctor. And when I came back, I was training in the West. And when I came back to Ontario and kind of moved back to the area where I was from, and the 10 years it took to get all of that training done, I thought I was going to have to go and open up my own clinic and kind of be the boss. And I got really lucky because in the kind of in that subsequent 10 years, I guess the provincial government realized that although Indigenous people make up approximately 5% of the population in Ontario, we actually spend closer to 10 or 12% of the healthcare budget. And when we're talking about the Ontario healthcare budget, that's billions of dollars.
Hmm.
And health outcomes typically are better when people that are, seen as being minority populations or vulnerable populations, outcomes are better when they're treated by people who look like them. And so they opened some they used to be called AHECs. We're an Indigenous interprofessional primary care team, but a primary care facility on territory for Indigenous patients. And although when I first came back, there wasn't a job open there, one opened up shortly after. And so that's now where my clinical practice is.
Wow.
Wow, that is so inspiring. I have to say, this is probably one of the most inspiring and winding journeys I've heard, but it just sounds like throughout the years, your community kind of kept pulling you back to where you needed to be, and you've not looked back since.
Yeah, and I
I
think. Sorry, go ahead.
I was just going to say, I agree, although I won't say that I'm not a little bit restless. And when I say that, like the kind of doctor hat that I wear is actually has now become a sort of smaller portion of like my professional kind of career and journey. And although it gives me like so much joy and it's such a privilege to provide culturally safe care in my home community, I see like, and I like kind of feel really deeply impacted by the fact that Indigenous people just don't experience the same level of health and wellness that non-Indigenous people do.
Hmm.
And like it's kind of it's an awful feeling to be a healthcare provider and know that. And kind of, I guess my that's kind of like led me like in my journey to think like, well, what can I do about that? And so I started getting involved in things, and really over a short period of time have become involved in a lot of things, in a lot of like medical education leadership and health leadership and health advocacy. And so I now sit on the board of the Indigenous Physicians Association, which is the like, Indigenous Doctors National Association. I'm the only Indigenous member of the Medical Council of Canada, which is the organization that is involved in licensing for physicians nationally. I'm co-chairing Ontario Health's first Quality Standards Advisory Committee on Indigenous health and cultural safety. I sit on the National Indigenous Deans of Medicine Council. Then professionally speaking, I'm the Indigenous Health Lead with Toronto Metropolitan University's School of Medicine. And so I've been involved in creating Canada's newest medical school for almost 2 years now. And then additionally, I hold a couple of leadership positions in the Department of Family Medicine at Queen's University, which is super fun because I get to teach medical students, family medicine residents, and other resident groups like cultural safety and anti-racism like skills training. So not only having that discussion of what's the difference between not being racist and being an anti-racist, but then, okay, now what does that look like in practice for you? And how can you implement some skills to move the system forward?
Wow. Dr. Cass, that's a lot. It's a lot of work that you've undertaken, and it's needed work. And I think one of the things that you kind of mentioned, and I think it's really important for us to kind of round the circle because we have a lot of different listeners. We have people that are patients, family members, healthcare providers, but I want to have a greater conversation in relation to Indigenous care, what you see as an Indigenous physician in your practice, because you mentioned that there are disparities. And I've heard conversations where, for example, I was at the grocery store just recently where I was overhearing a conversation and someone was like, "Oh, we now have two spirit on our applications. I don't know what that means." And I always take it as like, okay, maybe this is a learning opportunity. So what I'd really like you to do is maybe just describe, what do you see? Why do we need health equity? Why do we see disparities? And then I think we can take that and talk about the larger conversation about what Canada has to do as a whole. So we'll start with, what is it that you see? What is it that people need to understand about Indigenous healthcare?
That's a big question.
I'm
And you know what? I
sorry.
think, no, that's okay. I think if you asked 10 different Indigenous healthcare professionals, you'd get 10 different answers. But I have a slightly unique perspective, and that although I work in a First Nations community, I also sit at some kind of broader tables. And so I think the most important thing to understand is that essentially every single health disparity that exists in Indigenous people can be traced back to the legacy of colonization, like full stop.
Right.
Right.
And I think when you come to understand, and I'll maybe just take it a step further and say there are kind of like six-ish like legacies from European colonization of North America that impact Indigenous health today. They are the Indian Act, the reserve system, the residential school system, the Indian hospital system, the forced and coerced sterilization of Indigenous peoples that have a uterus, and then like the 60s scoop and like ongoing millennial scoop and birth alerts and the overrepresentation of Indigenous people in the foster care system. Only two of those things no longer exist.
Mm,
Wow.
yep. It's very shameful.
And then so if we think about that, that there are all of these systems and structures in place to keep Indigenous people, you know, in their place, then of course they don't experience the same level of health and wellness as other people.
Right.
Hmm.
And and I think there's a real lack of understanding of that. In general in Canada. And a lot of it is because we are such a multicultural group and lots of people just didn't do any of their education in Canada. So they lack that context. And then there are people who are, in my generation or older, and actually probably even some of them a little younger, who just weren't, the education system wasn't in a place that it shared any of this information with
Yeah.
people coming through the public education system.
Yeah, that's very frustrating. I think actually I just saw a news article today that there was not consultation on education for Indigenous people just recently, and with changes in curriculum. So, I mean, again, the consultation, one, needs to be there, and two, the education has to be there. And I think back to even my education, again, circling back to the 90s, and we were taught so little. And
Hmm.
a lot of the education focused on, the founding fathers and those colonial structures that perpetuated the racism that we see today in Indigenous people. And I think there, again, I don't want to say it's a rewriting of history because the history is already there, but it's telling the truth and telling the stories that we need to hear, and those stories that have been left off intentionally. So we have a well-rounded idea of what's actually happening and how we can move forward to change some of the healthcare outcomes that we see. You mentioned all of the history. So the 60s scoop, the Indigenous Act. I want to move to a greater conversation related to the CMA. So on September 18th, 2024, the Canadian Medical Association apologized for its role and the role of the medical profession in the past and ongoing harms of First Nations, Inuit, and Métis peoples in the health system. Could you tell us a little bit about this apology?
Yeah, absolutely. So I think probably one of the most significant things about that apology is that the CMA took the time to undertake like a significant review of the historical actions. So they looked through archives, they went through all of their social media accounts, they went back through parliamentary debates, they went through all of the committee records that they had, and then they had an independent ethics review based on their ethics and like code of conduct standards. Um, and they like explicitly named the harms, which is a
Yeah.
step that I'm sure you've seen other organizations kind of glance over or euphemize. Like they came out and said the historical review revealed that the CMA contributed to systematically embedding and upholding anti-Indigenous racism in healthcare, thus creating an unsafe environment for Indigenous peoples, patients, and communities. I have sort of uh, mentor and certainly a person, another Indigenous physician I just look up to so much, Dr. Danielle Ben-Smith. She's the Deputy Provincial Health Officer of Indigenous Health in BC, and she does a lot of anti-racism work. And a quote from her that I love is, "You got to name it to tame it." And so when people shy away from using the word racism, like, how are we ever going to do anything about it if we can't say it? And they named it. And I think that was really, I think it was critical and I think it was really impactful. Um, and they sort of owned a lot of the things I actually referred to earlier that were really specific to the medical profession. Things like the nutritional experiments that happened, the tuberculosis vaccine experiments that went on without proper consent and certainly no informed consent. The forced and coerced sterilization, like they named all of these acts and they owned their involvement. And and I think that's so important to be really, really clear about what they're apologizing for. So I think that was like incredibly well done. And the other thing that they did that I really like think spoke to the Indigenous community was they explicitly stated that reconciliation needs to be done in partnership with Indigenous communities. You alluded to something really important before, which is that, something that Justice Maurice Sinclair said which was we need to uncover truth and we need to truth tell before there can be true reconciliation. And so I think what the CMA did really well was uncovering those truths and explicitly stating them.
Yeah.
Yeah, I think that was a big move on behalf of the CMA because I can think of a lot of other organizations which have not stepped up, not named the things specifically that they play, the role that they played in the harms that came to Indigenous people. And do you feel like the CMA, what they did, does that go far enough? Or I feel like this is the beginning of more to come. Are there more barriers that are going to be coming up in terms of like moving some of this forward? Because I think the apology is one piece, but obviously there is a lot more that needs to be done.
Yeah, it's so apologies and statements like what the CMA came out with, they're so important and like of course they're absolutely necessary. What I more worry about, and I think I'm probably not the only person that does, is it's really challenging to kind of when declarations like this are made, if there isn't measurable accountability and sort of a timeline for change, then there's kind of the question of what comes next. And so the CMA does have what they call a reconciliation action plan. Um, but again, I just wonder about like what the specific accountability measures are. They sort
Mhm.
of outline kind of three broad areas. They say that they're hoping to advance Indigenous health, support physicians' journeys to truth and reconciliation, and then promote internal reconciliation for like the leadership within the CMA. And so that certainly they have ideas about what needs to be done. But again, like for me, like it all comes down to that accountability piece, right? Because it's what are you going to measure? When are you going to do it? And who's going to pay for it, right?
Yeah,
Yep.
It's
that's a big question.
and so that remains to be seen. I certainly agree that it's maybe a little bit too early to say what will come of this, but like they took like a significant and really important first step, which I think is very commendable. And I look forward to seeing what comes out of it.
Yeah, I think that's always kind of what Sarah and I kind of always look to. So, an apology is great. Again, There are steps. And when you're apologizing, so you apologize, but then there has to be some more action and accountability, like you mentioned, that has to come with it. And again, that's something that myself and Sarah, and I hope, many other people will be looking forward to seeing kind of what are those things, those measurable things, like you mentioned, that we'll be seeing. Because again, at the end of the day, we are still hearing those horror stories, right? I think back to even my own practice, and actually I had to go on stress leave at one point in time because the stories are horrifying. And again, as much as physicians, and I think Sarah alluded to this, that the CMA took this approach to apologize, we have yet to still see other organizations, or some of our own organizations, make these reconciliations, because this work has to be done not just with physicians, but right across the board. Because again, the buck stops with the patient, and at the end of the day, we all have to be all on board to really be able to see meaningful change. So I really hope that other associations look to the CMA as a starting point for an apology, but then we all work together through a systems approach to say, how can we do this so we can actually see change? What are the steps, the things that we're going to put in place to actually measure? Because those are the things that that mean the most. Because we don't want we when we say we want health equity, it also is about seeing better outcomes for those people as well. Um, we talked about next steps. What are some of the things that you might want to see? Have you thought about some accountability measures specifically that you want to see in terms of benchmarks or markers? And because at the end of the day, like I mentioned, we want to see that change for patients and families that are Indigenous. So do you have any ideas? Who are we gonna poke to start having conversations about accountability?
I have so many ideas.
Let's hear
I
them.
think So I think where we see some of the biggest gaps and some of the biggest inequities is when we're looking at rural and remote communities.
Mm,
Absolutely. And so, for example, if you live in rural or remote community and you become pregnant, you have to leave your community. You have to leave your people. You have to leave your culture. You have to leave your like spiritual practices behind to give birth and many or most of them. And whereas you or I don't, we have the privilege of not having that problem, right? So
right.
I think those are the communities that probably need support the most. And so when we're kind of looking at what could we do or what could be done next, I think it's really important that I mentioned that like that work has actually been done. And so I could kind of give you all of my ideas and they wouldn't be new because there have been so many like either Indigenous led or Indigenous co-created sort of calls to action, calls to justice, recommendations, articles in many foundational documents that are now starting to age, really, although they're still like very applicable to the health landscape in Canada. And I think we need to look to them because the work is done. So like for example, there's about six Truth and Reconciliation Commission final report calls to action that relate to Indigenous health. And I think one of the like most foundational ways to uplift health in Indigenous communities is number 23, which calls for governments to increase the number of it. They at the time the language is Aboriginal, but I'm going to say Indigenous professionals working in healthcare, ensure the retention of healthcare providers in Indigenous communities, and provide cultural like safety training for all healthcare professionals. If one of the TRC calls to action was meaningfully implemented, that single one,
Right.
that would be a game changer for like Indigenous like healthcare nationally, no question. And there are 94 calls to action, and that's only the TRC.
Yeah.
The Reclaiming Power in Place is the name of the final report from the National Inquiry into the Missing and Murdered Indigenous Women and Girls. They have 231 calls to justice, and a number of them relate to like health equity for Indigenous women and women, girls, and Two-Spirit people. There's the United Nations Declaration on the Rights of Indigenous People, and a number of those articles relate to Indigenous health. Joyce's principle had six recommendations, and then there's all sorts of sort of provincial guidelines and recommendations depending on where you are. So much hard work has sort of been done to go into what next. But for me, TRC number 23 is the big one.
I love that. And I
Hmm.
love that it's so specific that here's a starting place. Because sometimes, like you mentioned, there's a lot. Where do we start? What is the one thing that we need to, and I
Hmm.
think that
Hmm.
just really getting everybody on that same base is so important. So thank you for giving us that recommendation. And whose ear do we have to pull? It's like, what politician do we have to like string up and to have this conversation? And I think that, I think it's so important that we come to this place with understanding, right? Understanding that, we all have something to learn, right? I think that, there are some people out there might be like, I have an idea of how this should work. And it's like, no, we still need to come to this with understanding that we are all still learning and we're going to do this together. So I think that's a great place to start.
Yeah, and I think you've brought so many issues to light and things that I think our listeners are privileged to hear about. And obviously, I feel the passion. I know we've got so much going on and so many great ideas. Is there one more burning idea you'd like to share with us? Anything that we haven't touched upon or that you want to expand upon?
Maybe I will just speak to something you guys alluded to earlier, which is you were absolutely right that we need buy-in from everybody in healthcare, government, the people who run the health systems and the hospital systems, because you said something really important, which is that it's not just physicians that interact with patients, right? So if you think about this landscape of primary care really being struggle and millions of people not having a primary care provider, the default's the emergency department. And think about how many stops a patient has before they hit a physician in the emergency department, right? Like they get a check-in and then they get a triage and then they like a triage nurse and then they probably see, an emergency department nurse and then they might see a learner or two learners and then they sort of get to the physician. And so that are so many touch points where harm can be done before, even potential harm from a physician. And so it's just so important to get really like good appreciation, understanding, buy-in from everybody about how cultural safety it kind of is a shared responsibility and experience. And I'll just kind of maybe end by saying like cultural safety is an outcome. And so we don't actually know if we've gotten there until we ask the patient at the end of an encounter if they felt safe.
Right.
And so that takes everybody working together for sure.
Yeah, I think that's beautifully said. Where at the end of the day, like it's our patients and families hearing from them to say, did we hit the mark? Have we made change? Do you feel safe coming in? And I think that I think if we ask right now, we might have different answers, but there's a lot of work to do. And I think that as long as we're willing to do this work together, we will see change. And I'm a champion of this work being done. I think Sarah is as well. We're going to continue to lift our voices, poke at those politicians, because that is the bane of our existence. That again, we need to have people in power, shared power to see change. We need money. Like you mentioned, we need money and resources allotted to this. And then again, we do need that voice where everybody has a role to play. So I think that, this is a good start to having the conversation. Hopefully our listeners can say, here's something I can do at the end of the day, because I think sometimes people just don't know where to start, don't know where to have a conversation, where to find information. So we'll drop all the things that you mentioned in the links. And I hope we've shifted the conversation that we can see some more change and better healthcare outcomes for Indigenous folks.
Yeah. And Dr. Cass, if people listening want to know more about you or the work you do, how can they find you?
Oh my goodness, good question. I don't have a central place, but certainly the biggest bucket of health equity work I've been doing most recently is with like TMU's New School of Medicine, and we're slowly but surely like building our website up, and there's tons of information there about how like we work and how we've kind of done everything we can to infuse equity and really like reconciliation into the medical school from the ground up, and people there love answering questions, so you can always sort of reach out to them. But that's probably the best place right now, I would say.
Okay.
I'm sure when we type your name in Google, we'll find more than enough stuff in relation to some of the great work that you've been doing. So thank you so much.
I am embarrassingly Googleable right now.
No, it's okay.
For better or worse.
That is okay. Thank you so much, Dr. Jamaica Cass, for coming and joining us on the Gritty Nurse podcast. We hope to have you on again soon to have more conversations on how we can move to get together forward in relation to apologizing, as well as doing the most important work that we have to do to see better healthcare outcomes for Indigenous people today, forever, and always. Thank you so much.
Thank you so much for having me.
Thank you for listening to the Gritty Nurse podcast. If you have any suggestions or want to hear a specific topic, email us at grittynurses@cma.ca. greatynurses@gmail.com. That's greatynurses@gmail.com.
We are also speakers and authors available for engagements related to advocacy, nursing, mental health, and health policy. Please connect with us.
We want to take a moment to express our deepest gratitude to our incredible sponsors. Their generous support has been instrumental in making our podcast a reality.
Thanks to their belief in our mission, we're able to bring you engaging content and connect with our amazing community. We're truly grateful for your partnership. Thank you.